Welcome back, guys. Here we go again. We are now in the respiratory system. I finished the part A, which is the anatomy, and I did it in the QA session. So if you are interested in revisiting that, please go back to the recorded QA session video for October the 8th. And so now we're going to get into the respiratory physiology. Now, take note that pulmonary ventilation itself is made up of two phases. Pulmonary ventilation is what we know of as breathing, and it's made up of two phases. Inspiration is when gases flow into the lungs, and your expiration is when your gases would exit the lungs. And pretty much we will have to study in order to learn this. We'll have to study the relationships, pressure relationships in the thoracic cavity. So here you know that your thoracic cavity is bounded by connective tissues and your ribs. And that's exactly what the boundary is actually, the outer boundary is what the rib cage and the muscles are all about. Inside, it's not really empty. You have your lungs in there. So the cavity would have the lungs, and you have the heart in the middle of the thoracic cavity, which is in an area called the mediastinum. So the atmosphere, let's take a look at the pressure relationship of all the other pressures that are involved in delivering air into our body. First of all, your atmospheric pressure is equivalent to 1 atmosphere or 760 millimeters of mercury pressure, and is actually the pressure exerted by the air surrounding the body. So at sea level, the pressure of air is 760 millimeters of mercury pressure, or is equivalent to 1 atmosphere. That's right there. And pretty much inside our lungs, we have also relative pulmonary pressures, okay, that we describe relative to that particular atmospheric pressure. And just know that there is negative pressure. When you say negative pressure, the pressure should be less than the 760 millimeter of pressure at sea level. For instance, when you say negative pressure, it could be 754 millimeters. That's already negative pressure because it is less than 760. Positive pressure will be the pressure that is higher than the 760 millimeters. Okay, so greater than 1 atmosphere. So the zero pressure is when the pressure is actually equivalent to the pressure in the atmosphere. You call that zero pressure. So let's take a look and view what intrapulmonary pressure is. It is a pressure that resides inside the alveolar sacs, and it's also known as the intra-alveolar pressure. Now, this would be fluctuating when we are breathing, and it is always or will eventually be equalizing to the atmospheric pressure. So even when it is changing, sometimes it becomes higher than the atmospheric pressure, sometimes it becomes lower. Eventually, the net effect should be eventually to equalize with the atmospheric pressure. And the reason why we are moving our chest is because the air is trying to, or rather the pressure outside and inside our lungs or our alveolar sacs are trying to equalize. So the intrapleural pressure is the pressure that is found or felt inside the pleural cavity. So what is the pleural cavity again? According to our anatomy last week, the pleural cavity is the cavity in between the lungs and the parietal wall of the thoracic cavity. And it also fluctuates with breathing. And there is always negative pressure in that particular area right there. It is always 4 millimeter, as like 4 millimeter less than the pulmonary pressure. Now, take note that this negative pressure is necessary in order to keep the lungs or the walls of the lungs adhering, not necessarily physically adhering, but really like being pushed to really connect with the wall. The lung tissue or the walls of the lung is supposed to really like expand and keeps connected or keeps to be abutting into the parietal wall itself. So in order to be doing that, there must be 4 millimeters of mercury less. That's actually already negative pressure. So if your pressure outside is 760 millimeters of mercury, the pressure inside the intrapleural is actually 756. Okay? And therefore, the fluid inside or in between that um, intra in between the intrapleural area is always kept at a minimum. If there's going to be excess fluid there, it should be pumped out by our lymphatic system. It has to be reabsorbed. Now, if there's going to be fluid that's going to be accumulating there, then the positive pressure would develop in between the intrapleural pressure, and that would cause the lungs to collapse. It could cause what you call a pneumothorax. So the intrapleural pressure, which is known as the PIP, are the two inward forces that can promote collapse of the lungs. Usually the lungs has a general tendency to recoil, to collapse. That's a tendency of the lungs, to collapse. Why is it that the lungs has a tendency to collapse? Well, inside the lungs are tiny sacs, millions of tiny sacs, which we call alveoli. Inside the alveoli, you have walls, the alveolar walls are lined with water. And the water has surface tension. And those little water molecules are clinging onto each other and pulling onto each other. That's actually what you call surface tension, and is inviting the collapse of the alveoli. So that is actually the reason why the lungs would have a natural tendency to recoil. And because that's also because of surface tension of water, and then the elasticity of the lungs, which is always trying to assume the smallest size. And there you go, the surface tension of alveolar fluid is actually pulling the alveoli to reduce the alveolar size. So the intrapleural pressure, or the PIP, pretty much is the outward force that tends to enlarge the lungs. Elasticity of the chest walls would pull, okay, the thorax outside, and a negative PIP is affected by these opposing forces, but is maintained by the strong adhesive force between the parietal and the visceral pleura. The adhesive force in the parietal and visceral pleura is not really a physical, well, it is a physical contact because they're actually touching each other, but they're not literally like connected. No, they're not. There is a space, it's an interpleural space between them. But because of the negative pressure, then that particular adhesive force is maintained. So the transpulmonary pressure. The transpulmonary pressure is the atmospheric, the pressure in the alveoli minus the intrapulmonary pressure. Okay, it is a pressure that keeps your lungs open. Okay, it keeps the lungs from collapsing. The greater the transpulmonary pressure, the larger will be the larger will be the lungs, and the lungs, larger will be the possibility that the lungs will collapse. Okay, um, and pretty much if your intrapleural pressure is equivalent to the pulmonary pressure, or the pressure in the alveolar sacs, um, or if the intrapulmonary pressure is equal also to the atmospheric pressure, then the lungs will collapse. So negative pressure, in the end, negative pressure must be maintained in order to keep your lungs inflated. This is actually the sucking effect. Negative pressure is the sucking effect on the sucking effect on the lungs, so that the lungs will keep expanded. So, okay, this is actually something that is really good to highlight, pretty much with maybe a pen. Okay, here's actually your uh, intrapleural pressure, and take a look at this intrapleural pressure. And this intrapleural pressure, you have pretty much right there. It's actually -4, and that's actually the negative pressure. That -4 is pulling this wall going towards that end there. Okay, so it's actually keeping the wall from collapsing. It is like a sucking motion that's actually pushing it to that towards the parietal. Okay, that's actually what the purpose is of the -4. So if 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 the pressure inside the lungs is greater than the atmosphere, what's going to happen is that right here is an open thing, right? Right in this particular area, this is open. If the pressure inside your thoracic cavity and inside your lungs is so great, the only thing you need to do will be to open your mouth and air rushes out. That's There's no magic in it. Air would rush out. Okay? But when the pressure inside this thoracic cavity becomes lower, and how do you lower the pressure inside the thoracic cavity? Well, when the diaphragm moves down, okay, when it flattens out, when we are breathing, when the diaphragm is flattening out, okay, lowering down, that will increase the volume inside your thoracic cavity. And when the volume inside the thoracic cavity is high, then the pressure is low. Okay, they are inversely proportional. The pressure now is going to be uh, lower than the 760 millimeters of mercury pressure outside, and therefore the tendency of the air will be to get in. So our breathing, okay, has got something to do only with the changes in pressure between the outside of the lungs and inside the lungs. However, our lungs needs to stay inflated, okay, without the negative pressure that is right there, the negative pressure that you see right in the uh, um, without the negative pressure that you see right in the air, in the gray area right here, the lungs will collapse. All right. Anyway, okay. So let's take a look at the next one. So, what happens when a person gets into a situation which we call pneumothorax? Pneumothorax could happen whenever there is a rupture, either in the parietal, that red area right there. Okay, the red area right there is actually the parietal pleura. Okay, or the visceral pleura. The visceral pleura is the very thin layer of cover that covers the lungs, and then the gray area is the intrapleural space. Okay, so pretty much the pleural cavity needs to be maintaining the negative pressure so that it can pull the lungs closest to the parietal wall, and that needs to be maintained. Now imagine if you're trying to maintain that pressure and all of a sudden somebody shoots you, and the bullet or somebody like pretty much like punctures you or stabs you, then and the knife will enter right through your thoracic cavity and into your lungs. That would pretty much like not really necessarily to the lungs, just puncturing the parietal pleura. That will now reduce the negative pressure and your lungs will collapse. That's one way of collapsing the lungs. This is a a reason why a pneumothorax will happen. Or another one will be whenever there is actually a rupture in the visceral pleura, okay, like this. So, what would be the cases where a visceral pleura would be ruptured? Well, in cases where there is already a disease there, that's already like damaging the cover of the lungs, a pleuritis, a pleurisy, okay, which is leading already to, let's say, pneumonia, that could rupture that particular cover of the lungs, and that could lead to a collapse of the lungs or pneumothorax, okay? So pretty much a pneumothorax, therefore, is the air. There's actually air that's going to enter the pleural cavity. Can you see the difference? These are supposedly your normal lungs that has. This one has a rupture inside the visceral pleura, and this one here has a rupture in the parietal pleura, and it will lead to the loss of the negative pressure. When there's loss of negative pressure, the lungs will collapse. Okay, take note that the the pleural cavity here, the gray area became bigger because the lungs had collapsed. Okay. So atelectasis is a condition where the lungs would collapse due to plugged bronchioles, which causes the collapse of the alveoli. So this is different, although the effect would be the same, different from pneumothorax. In pneumothorax, you puncture the parietal the parietal cover and the visceral cover of the lungs. Therefore, you are losing the negative pressure, and the lungs will collapse. With atelectasis, the reason of the collapse is because of plugged bronchioles, okay, or uh, pneumothorax. Okay, pneumothorax is also a collapse of the lungs because of air in the pleural cavity, just like what we discussed in the previous slide. Okay. Okay, this pneumothorax can be treated by removing air with chest tubes. What they do is they insert tubes into or in between in the pleural cavity, and they're going to suck out that particular air and then pull it out and let the lungs tissue heal itself and with the negative pressure. So now let's get into breathing itself. Breathing is pulmonary ventilation. It's made up of two phases, inspiration and expiration. These are mechanical processes that depends on volume changes in the thoracic cavity. Volume changes lead to pressure changes, and pressure changes lead to flow of gases to pretty much like equalize pressure. And pulmonary ventilation follows, physics as well. And this is exactly how they studied our way of breathing by just looking at the behavior of gases in and out of our lungs. So the first gas law is Boyle's law. Boyle's law is the relationship between pressure and volume of gas. And pretty much when gases fill a container that they are in, they are actually providing pressure, or the gases inside is applying pressure on the container. Now, if the amount of gas is the same, all right, and then you reduce the container size, then the pressure will increase. You're trying to, okay, imagine this, okay, you imagine that your container is a balloon, all right, and you have an X amount of gas in the balloon, and you put that balloon in between in your hand, okay, and then squeeze the balloon so that you are reducing the the size of the balloon by squeezing it down. Are you not increasing the pressure inside? Yes, you are. All right. So pressure, therefore, varies inversely with volume, okay, which means when pressure is low, the volume of the container, okay, must be bigger, than the amount of gas inside it. But when you reduce the volume, the pressure inside will increase. So mathematically, you want to express that in mathematically. Okay? This is actually how it is. PV or PV1, okay, sub 1 is equal to PV sub 2. That's actually inversely proportional. So let's take a look at uh, inspiration, which is the main component that we're going to take in pulmonary ventilation. It's an active process involving inspiratory muscles, your diaphragm, as well as your intercostals, your external intercostals to be more precise. And here, the diaphragm, which is actually dome shaped, would contract. And when it contracts, it flattens out. Okay, the flat diaphragm is the diaphragm contracted. The dome-shaped diaphragm is the diaphragm relaxed. Okay, the muscle of the diaphragm is relaxed. Okay, so when the diaphragm flattens out, it results in an increase in volume. And I explained it to you in the first page that I explained to you moments ago. And pretty much the action of the diaphragm is just to go up and down. The intercostal muscle, on the other hand, when the external intercostal contract, the rib cage would be lifted out. So it's much like when the handle of the bucket is actually raised outward, it outward as it moves upward. Okay. So uh, in the end, the result of that is increased in thoracic volume. Okay, so the action of the intercostal muscle moving the rib cage out, and if it contracts, it's moving or flattening the diaphragm. It's actually enlarging the volume of the thoracic cavity. When it enlarges the volume of the thoracic cavity, the pressure inside the thoracic cavity will now become lesser than the atmospheric pressure. So what's going to happen if the pressure inside the thoracic cavity is lesser? Well, just by law of diffusion, you open your mouth and air gushes in or rushes into your thoracic cavity. There's no magic in our breathing. It's just a movement of air or diffusion of air from an area where there's too much pressure of them to an area where there's less pressure of them. So right here, whenever your rib cage pretty much opens up, okay, when it opens up and expands out, and then your volume inside is going to be increased, and evidently your air would rush in. Okay, air would now rush in. So, as thoracic cavity volume increases, your lungs will stretch. Okay, they are pulled out with the thoracic cage, and it will cause the intrapulmonary pressure to drop by 1 millimeter of mercury, and that's enough. 1 millimeter of mercury pressure is one enough. Okay, and because of the difference between the atmosphere and the pressure inside the thoracic cavity, then air will rush in. Okay. Inspiration would pretty much like probably uh, be of different nature. Forced deep inspiration, for instance, can occur whenever there's vigorous exercise, or pretty much with people or among people with chronic obstructive pulmonary diseases, COPD. This is actually where accessory muscles are activated. Okay, your scalenes, your sternocleidomastoid, your pectoralis minor. They're also activated in order to force your thoracic cavity to expand out. Okay, even your erector muscle, which is actually muscle of the back, is also going to contract in order to help straighten the thoracic curvature. Okay, and pretty much they act to further increase, they all act, these accessory muscles will all act to further increase thoracic cage, creating a larger pressure gradient so air is actually drawn in. This is actually the effect of when you are actually sighing. You're trying to increase air from getting inside your lungs. Okay, so it's not sighing. Sighing is actually expiration, but increasing your air. Before you sigh, you inhale, okay, big, and that's actually with the use of other accessory muscles. So here's actually a sequence of events, okay, just to review. First, in inspiration, the inspiratory muscles contract, okay, this will descend, the diaphragm will descend, the rib cage will rise, then your thoracic cavity volume will increase, and that right there, and then the lungs are stretched, and your intrapulmonary volume will increase. Then the intrapulmonary pressure drops to 1 millimeter of mercury pressure, and eventually air will now flow into the lungs down its pressure gradient until the intrapulmonary pressure is zero or is equal to the atmospheric pressure. So expiration, which is really like breathing out air, is really a passive process. Usually, the muscles doesn't need contract. The muscles just would go back to the relaxed stage, and when they are relaxed, the diaphragm rises again. The rib cage would fold down, and that would pretty much like reduce the size of the thoracic cavity, thus pushing air out. Okay, as the lungs will recoil, okay, the volume decrease causes the intrapulmonary pressure to increase by 1 millimeter. And because there's now greater pressure inside, you open your mouth and your air, you're breathing out air. But forced expiration is different. Forced expiration is an active process that uses more muscles like your oblique and transverse abdominal muscles as well as your internal intercostal muscles. Okay. So this is something that you can look at in your spare time, guys. Okay, so this is also a very good way. This is actually figure 22.17 in your textbook. Please go and visit this and take a look at the changes in the intrapulmonary and intrapleural pressure during inspiration and expiration. So let's take a look at some non-respiratory air movements. Many processes can actually move air into and out of the lungs besides the breathing that we are talking about now. They can modify normal respiratory rhythm, and most of them result from reflex actions, although some are actually voluntary. Example of this will be when we are sneezing, coughing, when we are crying, when we're laughing, even hiccups or yawning. These are processes that move air into and out of the lungs. All right, new topic. Let's take a look at the physical factors influencing pulmonary ventilation. There are three physical factors that influence the ease by which air could get inside, okay, and the amount of energy that's required for ventilation. First of all, airway resistance. You have alveolar surface tension, and the third will be your lung compliance. These are factors that would affect the ease by which air could get inside the lungs. Okay, let's take a look at airway resistance. This is really nothing but friction. Okay, the major non-elastic source of resistance to gas flow always occurs in the airways. And the relationship between the flow, which is F, and pressure and resistance is shown right here in this particular formula. Well, F is equal to change in pressure divided by the resistance. And the change in pressure gradient between your atmospheric and your alveolar pressure, which is about 200 millimeters of mercury pressure or less during a quiet, normal breathing. I am not going to be giving you any. I just want you to know that the flow is inversely proportional to pressure. I mean to resistance. Okay, and directly proportional to pressure. And pretty much, I am not going to give you any calculations in the lecture exam. Airway resistance, okay, is the resistance in the respiratory tree that is usually insignificant, really. And that is because the diameters of the airway in first part of conducting zone are big. They're really huge. And the progressive branching out of airways as they get smaller leads to an increase in total cross-sectional area. So any resistance usually occurs in the medium-sized bronchi, okay, not in the very big ones. And um, pretty much the diameter is being held in place as large because of the cartilage, the C-shaped cartilages in the trachea. So resistance would disappear at the terminal bronchioles, where diffusion, okay, is what would be driving the movement of the gas after this, right? Let's take a look at some homeostatic imbalances, okay, in airway resistance. As airway resistance rise, breathing movements become more strenuous. Severe constriction or obstruction of the bronchioles, when your bronchioles are plugged with mucus or is actually constricted, this can prevent air from getting in, and they are actually life-sustaining gas. It can occur when we have acute asthma, okay, and that would eventually stop ventilation. So you need a bronchodilator. And epinephrine, the effect of epinephrine is to dilate the bronchioles, okay, and to reduce air resistance. That's why if you have an extreme asthma, if you have an asthma and you know that you're going to have an asthma attack, you're not going to be able to breathe. And therefore, one of the things that these people have will be an epi, a handy epi around. And a shot of epi is all they need. So, alveolar surface tension. Take a look at alveolar surface tension. Isn't this the surface tension that is brought about by the attraction of water molecules to each other because of its polarity? Okay? And they tend to draw the liquid molecules closer together to reduce contact with other molecules, and they resist any force to increase the surface liquid area, okay? And pretty much they tend to cause the alveoli to shrink and to collapse. So the surface tension of water has a pulling effect, okay? Not elastic, but because they are cohesive and they are clinging to the wall of the alveoli because they're also adhesive. This is actually the property of water. As they are actually contracting and is actually attracted to form hydrogen bonds with each other, they're pulling on each other, and they're pulling the lungs into collapse, the alveolar sacs into collapse. So alveolar surface tension can actually be eliminated if you can break the hydrogen bonds. And surfactant is a protein, okay, like a detergent type like of a protein that helps reduce surface tension of water inside the alveoli. It prevents the collapse of alveoli. And this is produced by type 2 alveolar cells. Now, the type 2 alveolar cells are not yet fully developed in the womb. If the baby is only like 6 months old in the womb, therefore, premature babies who are born before they are 7 months old, usually they start kicking in, producing surfactant at age 7 months. When baby is 7 months, there is less chances of lung collapse. However, when the baby is born really very early, like 6 months, the type 2 alveolar cells are still unable to produce surfactant, and therefore the baby is kept in an incubator with mists, okay, constant mists of surfactant that it can breathe, so that its lungs will not collapse. And that goes for almost like a month, or until its own alveolar sacs will be able to produce its own surfactant. So, and that's actually what you call the infant respiratory distress syndrome. Okay. Uh, so here your alveoli must be completely reinflated during its inspiration, and they use tremendous amount of energy, very common in premature babies. Usually the lungs will collapse if they're not going to be given uh, surfactant in order to reduce the uh, uh, the surface tension. Okay, the treatment for this, for for premature babies, and so that they will survive, is to spray natural or synthetic surfactants into newborns' air passages. Usually, they mist the incubator of the baby with synthetic surfactant, and of course, positive pressure devices will also help to keep the alveoli open between breaths. Okay. Okay. Let's now go to get into other factors. Let me see. Lung compliance. Lung compliance is a measure of change in the lung volume that occurs with given change in transpulmonary pressure. It's actually the measure of how much stretch the lung can actually give us. Usually it is high because of the ability of the lungs to distend. The lungs is distendable. Okay. And three much surfactants, which uh, decreases alveolar surface tension, is um, good. It increases lung compliance. Okay, higher lung compliance means it is easier to expand the lungs. Therefore, surfactant would increase lung compliance. So I am not going to give you anything. You don't need to memorize mathematically this one. Just make sure that you know right on this section right here, okay, from this bullet right here, from this bullet right here all the way down, okay, just what that particular formula means, okay. It can be, just make sure that you know that lung compliance is is actually something that we want to provide for better breathing. And the way to do it is that we try to, for newborn babies, we try to produce more surfactant from them so that their lungs can actually distend. But for adults, our lung compliance will not have a problem, not unless we get into something like a disorder, like non-elastic scar tissue, which would be replacing normal lung tissue, as in people with fibrosis. Their lung compliance is actually reduced, or reduced production of surfactant, or maybe decreased flexibility of the thoracic cage. Now imagine yourself, okay, it's exactly like what you call restrictive breathing. Imagine yourself, for the girls, wearing a bra, a tube bra that is so tight you cannot breathe. You cannot expand your lungs because of the tightness of that elastic material that you're just wearing. Now that would decrease the flexibility of the thoracic cage. That's going to reduce lung compliance. You are unable to extend your lungs the way it's supposed to be. That's actually restrictive breathing. Any decrease in the natural resilience of the lung would diminish lung compliance, even if it's only wearing that ridiculous, abnormal, tight bra. Okay? Or it could be chronic inflammation or infection, such as tuberculosis, which can cause fibrosis. Okay? or decreased production of the lungs, which can impair lung compliance. Okay, the more or the lower the lung compliance, the more energy is needed just to breathe, and therefore you see people with COPD um, uh, really exerting a lot of uh, using up a lot of energy just to breathe. Really, and I have seen that, and I I would know that personally because my my late husband, before I got married with Mr. Queen, my late husband, Mr. Campanero, died of pulmonary fibrosis. So, total lung compliance of the respiratory system could be influenced by um, distensibility of the thoracic wall, which can also be decreased by some deformities in the thorax. Okay, if your rib cage is not distensible anymore because of calcification of your cartilages, okay, that makes your rib cage really a little bit more pliable, then that's going to be a deformity. Yeah, there we go, ossification of the costal cartilages. And these are very common among old people or as we are aging, or if there's actually any reason that can cause to the muscles of the intercostal area to be paralyzed. All right, so let's take a look at um, how we assess pulmonary ventilation. Usually, I do not discuss this in the lecture because you have this um, in your in your lab. And in your lab, you're supposed to be reading on it and trying to figure out exactly what it is. But I'm going to give you a brief lecture on this so you will understand it better. Okay. Now, several respiratory volumes are used in order to assess the nature or the validity of how well we are breathing. Okay. So the status is brought about by studying respiratory volumes and can be combined to calculate capacities. Remember that volumes are just the amount of, let's say, gas for a particular action of breathing, like inspiration or expiration, okay, or silent breathing. Those are actually the amount of gas that is necessary. There will be the volumes, but respiratory capacities will be different. This will be combination of volumes, okay, which could pretty much give a clinician information about a person's respiratory status. So respiratory volumes and capacities are usually abnormal with people who have pulmonary disorders. So you have normal pulmonary volumes and normal pulmonary capacities at standard, that is actually standard for uh, among all people, and it depends on your size also. Not everybody would be equal, most especially if the size of your lungs and your rib cage are different. So it is dependent upon the lungs, I mean, the size of the rib cage and the lungs. And anything that is lower than that could either be an abnormality or possibly a reason for thinking that you have a disorder in your lungs. And a spirometer is something that we use in the lab, but you cannot use anymore now. Pretty much is originally been used. It's very cumbersome clinical tool that's used to measure patients' respiratory volumes. We still use it in a standard lab to assess pulmonary capacities. But now, there's actually you don't breathe on anything anymore. You use electronic measuring devices. So let's take a look at respiratory volumes. Tidal volume is the amount of air that you move into and out of your lungs during a regular, normal, silent breathing. Okay, when you're silently breathing, you're not sighing, you're not extremely agitated, you're not breathing so much and expiring so much. Just your silent, normal breathing when you are watching the TV. That's actually your tidal volume, and it averages about 500 ml. But then again, depends on the size of your lungs. And people who are really very little can have lower than that. Like I am very tiny, and my tidal volume, as far as I could remember, it is, I think, only about 350 ml. Okay, so the inspiratory reserve volume, or the IRV, is the amount of air that can be inspired forcibly, meaning inspired, breathe out forcibly beyond the tidal volume. And it's about 2100 to 3200 ml of air. That's big. Then you have the expiratory reserve volume. It's the amount of air that can be forcibly expelled from the lungs. It's about 1000 to 1200 ml. Residual volume is the amount of air that always remains in the lungs. Okay, this is actually necessary in order to keep the alveoli open. And whenever your lungs are actually in its normal state and it's not collapsed, it's not undergoing pneumothorax, you should have a residual volume right there in order to equalize pressure with the outside. So, pretty much, capacities, just like what I told you, will be the combinations of two or more volumes. For instance, your inspiratory capacity would be the sum of the tidal volume plus the inspiratory reserve. Your functional residual capacity is the sum of the residual volume and the expiratory reserve volume. And your vital capacity is the sum of all three, the tidal volume plus the inspiratory reserve plus the expiratory reserve volume. That's actually almost like the vital capacity. And the total lung capacity is the sum of all, okay, which is, remember, your vital capacity right here, notice that doesn't have any reserve volume, okay, because that's actually the capacity of your lungs when you are in your daily movement, all right? But it does not include the reserve volume right there. But when you reserve when you include the reserve volume, then you are talking about the total lung capacity. It's a sum of all the lung volumes. Okay. So take a look at this whenever you have the chance. Okay. Now, let me go back to here. I am pretty sure that you are in your lab, and make sure that you know that your respiratory capacities, the formulas for the respiratory capacities will be this one, and it is actually part of the lab that you're doing in the respiration. I guess it's already done because your lab exam is already finished with it. Okay. Dead space. Anatomical dead space. It pretty much does not contribute to gas exchange and consists of air that remains in the passageway and about 150 ml to about 500 ml tidal volume. And alveolar dead space is the space occupied by non-functional alveoli and can be due to collapse or obstruction of the lungs. And the total dead space is the sum of the anatomical as well as the alveolar dead space. So pulmonary function test can be taken by spirometry and can be distinguished between obstructive pulmonary disease and which is characterized by increased airway resistance. An example of this will be bronchitis. And here you will have an increase in the total lung capacity and the functional residual capacity, the reserve volume. This may increase because of hyperinflation of the lungs. And then the restrictive disease, this is actually where your lungs is unable to expand. It's just like wearing a tight bra and you cannot expand your lungs. This will be characteristic of pretty much diseases like tuberculosis or exposure to environmental agents such as fibrosis. And pretty much here your vital capacity, your TLC, your FRC, your RV declines because lung expansion is compromised. Make sure that you know this, guys. I am going to give this in your lecture exam, next lecture exam. So pulmonary function test can be measure rate of gas movement. Okay, and the amount of your FVC, or the forced vital capacity, is the amount of gas that's forcibly expelled after taking its breath. And the forced expiratory volume is the amount of gas expelled during a specific time interval, only a specific time interval. This doesn't have the FVC doesn't have any time interval, but when you put a time interval, let's say the amount of FEV1 is the amount of air expelled in the first second. Okay. Now, healthy individuals usually can expel 80% of FVC in the first second. Okay, patients with bad obstructive disease exhale less than 80% in the first second, whereas those with restrictive disease would exhale 80% or more, even with reduced FVC. So these are all clinically studied and are standardized, and the clinician can actually determine whether a person would have a disorder in their breathing whenever there is a difference in the in their data. Okay, I am not going to give this minute ventilation anymore. Okay, let me just go through it. Okay, and let me just move on into gas exchange. Gas exchange occurs between lungs and blood, as well as blood and tissues. And you have external respiration, which is a diffusion of gas between blood and lungs. And your internal respiration is a diffusion of blood between blood and tissue. So the difference here is only where exchange is actually happening. External respiration happens between blood and lungs. Internal respiration happens between blood and tissue. Both of them, though, are processes that are subject to basic properties of gas and composition of your alveolar gas. So let's take a look at the basic properties of gases and learn again another law of physics, which is Dalton's law of partial pressure. According to Dalton's law, the total pressure as exerted by a mixture of gases is equal to the sum of pressure exerted by each gas. How much, or what are the gases that you find in the atmosphere? Well, there are three major gases, okay, that is pretty much like you can detect more, okay, but in minimal amount, that is absolutely affecting our breathing. And that is, these are the gases where the pressure exerted by these three gases is equivalent to 760 millimeters of mercury pressure. The greatest among all of them is the pressure that is exerted by nitrogen gas. About 78% of the air that we're breathing in is actually made up of nitrogen gas. Then you have oxygen. Oxygen, probably about 21% is oxygen, and a good 0.3% or 0.03% is actually your carbon dioxide. Now, between all these three gases, you have the partial pressure, okay, of these gases, and is equal to pretty much the total atmospheric pressure, which is 760 millimeters of mercury. Okay, so there you go. The total atmospheric pressure equals 760. Nitrogen takes up 78%. Okay, and pretty much is equal to 597 millimeters of mercury pressure. Your oxygen supplies about 21% of air, which is equivalent to about 159 millimeters of mercury pressure. And your carbon dioxide is really very small, all right? But you cannot discount it because carbon dioxide is still part of the air that we are producing, and is actually breathing out. Which therefore, about 0.04% of the air that we're breathing in, not 0.03, but 0.04, is actually carbon dioxide. And about 0.5% is water vapor, and some other significant amount of other gases. At higher altitudes, although partial pressure would decline, but at lower altitude, meaning if you're underwater, the partial pressure will significantly increase. Okay. Here is actually a comparison of gas partial pressure. So you will see the difference between your nitrogen, your oxygen, carbon dioxide, and the water vapor. Okay. And they all sum up to 100% right there. So let's take a look at the properties of gases, each of these gases, nitrogen, oxygen, carbon dioxide, okay, and how it is affecting our ability to breathe in. Most especially, we are discussing here breathing and respiration, and the important gas here is none other than oxygen. Let's take a look at Henry's law. For gas mixtures in contact with liquids, its gas will dissolve in the liquid that is in proportion to its partial pressure. At equilibrium, the partial pressure in the two phases should be equal. The amount of each gas dissolved will depend on the solubility of each gas in water. Okay, for instance, carbon dioxide is 20 times more soluble in water than oxygen. Are you not happy that this is so? That carbon dioxide in the atmosphere is only 0.04%. Any increase in carbon dioxide in the atmosphere will be catastrophic to a lot of living organisms because carbon dioxide is really 20 times more soluble than any of the other two gases that is coexisting with the air that we're breathing in. All right. And then your nitrogen, on the other hand, nitrogen is 78%. That's a big chunk of air. But nitrogen is virtually insoluble in water. And therefore, we take it in and then we take it out, and it doesn't dissolve much in the water, not unless you are exposed to high pressure. Now, the solubility of carbon dioxide is the greatest among the three. But because it is the least in content, then we don't need to worry about it. Okay? The one that is the next soluble is actually oxygen, even if it is actually right there in the medium, but it's only 25% of the atmosphere, not really that much. So we're breathing in the gas that we just need, just in the right amount, in the right pressure. We do not want really to be breathing in high pressure oxygen, because that could also be catastrophic to us, because it can pretty much result in an increase in what do you call this, in substances that we don't want to increase in our body. So temperature affects solubility. As the temperature of liquid rises, the solubility would decrease. And an example of this is actually of Henry's law is the use of hyperbaric chambers. Okay, you've heard of the bends. Okay, whenever you go diving and you increase your nitrogen content in your body, you have to eliminate that nitrogen content because of the increase in pressure. You're actually like taking a lot more of the nitrogen. You have to exhale it out slowly. And therefore, when you're ascending, when you are out there, when you're down there in underwater and you're deep sea diving, you have to ascend very slowly in order to give the nitrogen the chance, in order to give your body the chance to exhale nitrogen at the regular rate. If you ascend very fast, then you're keeping some of the nitrogen that you're supposed to breathe out deep in your tissues, and that could become really bad for you. Okay, it can cause, if it's in your brain, it can cause some sort of mild hallucination. If it is in your joints, if the nitrogen bubbles are in your joints, it can cause what do you call this, pain in your joints. Okay, and then here, breathing oxygen, just like what I told you, at high temperature, at high atmosphere, meaning you want to breathe in more of the oxygen and almost the pure oxygen, okay, we can develop toxicity to oxygen because a lot of oxygen would generate a huge amount of free radicals. Okay, that's why we have what you call antioxidants, because we're breathing in oxygen and we are producing anti-radicals with it. Even at a normal rate, we are actually trying to remove that anti-radicals by eating antioxidants, right? Antioxidants will reduce the amount of free radicals that are being produced by our body. But if you're going to constantly, if you're going to be breathing in pure oxygen, you're increasing the possibility of producing more of these free rads. Okay, so let's take a look at the composition of alveolar gas. Alveoli contain more carbon dioxide and water vapor than the atmospheric air. And it's because of gas exchanges in the lungs, okay, where oxygen diffuses out of the lungs and carbon dioxide diffuses into the lungs. And humidification of the air by conducting passages, mixing of alveolar gas with each breath, and newly inspired air mixes with air that was left in passageways. That's between breaths. Okay. So let's take a look at external respiration. External respiration is the exchange of gas between the alveoli and the air outside. And it involves the exchange of carbon dioxide also and oxygen across the respiratory membrane. And is influenced by partial pressure gradients and gas solubilities and the thickness and surface area of respiratory membrane, and also the ventilation perfusion coupling, which is the matching of the alveolar ventilation and the blood perfusion or taking in of oxygen. So the partial pressure of gas, the partial pressure gradient and gas solubilities tells us that pretty much the steep partial pressure gradient for oxygen would exist between the blood and the lungs. Okay, in the venous blood, the partial pressure of oxygen is 40 millimeters of mercury. In the alveolus, the partial pressure of oxygen is 104, and that is steep. Okay, meaning if you are going to be really just relying on that partial pressure between the alveoli, which is 104, and your 40 on the venous blood, your alveolar oxygen will pretty much be diffusing, driving crazily into the blood to get into the venous blood because it's from high to low concentration. That's the way diffusion flows. So this is actually the one that drives oxygen to flow from your alveoli into the venous blood. So as soon as equilibrium is reached across the respiratory membrane in about 20.25 seconds, okay, pretty much that happens right there. But in the blood, it takes the red blood cell about 0.75 seconds to travel from the beginning to the end of the pulmonary capacity. So it's about almost like more than a minute. So there is actually what do you call this, the drive to diffuse, okay, even when it is being carried by the red blood cell. So the partial pressure though for carbon dioxide is not really big. It's only about 5 millimeters of mercury pressure, where your venous blood has 45. This is actually the high carbon dioxide level. When we pick up CO2 from the tissues, our CO2 level in blood is 45. But in the alveolus, it's only 40. So there is actually only 5 millimeters. So it's not really like gushing air as in the oxygen steep pressure. But that is still a pressure gradient, okay? Though it's not so steep, the carbon dioxide still diffuses in equal amounts with oxygen. And the reason that is carbon dioxide is 20 times more soluble in the plasma, okay? Remember that carbon dioxide is more soluble in water, okay, and than in the alveolar fluid than oxygen itself. And take a look at this, guys. I am probably going to be uh, explaining this to you. Take a look at outside here, right in this particular thing here. I can explain to you just by using the slide how air is actually moved from the outside, from the atmosphere, into the alveolar sacs, into the blood, into the tissues, from the tissues back out into the venous system, and then back into the lungs, and then outside. And it's all because of the partial pressure gradient that promotes gas movement. Right here, you can see in red, right there, the inspired air, which has 160 millimeters of mercury pressure of oxygen. Okay, inspired air, and it has only zero point 0.3 millimeters of carbon dioxide. This is air that's actually getting inside the alveoli. In the alveoli itself, the uh, oxygen is only 104. So imagine the difference between 160 and 104. So from the air outside to the air inside the lungs, you're actually taking in, or oxygen really is going to be driven from 160 to 104 to diffuse into the lungs, right? Meanwhile, the difference between the level of carbon dioxide between inspired air is actually zero point 0.3 millimeters, okay, of mercury, and 40 millimeters of mercury pressure outside. Therefore, carbon dioxide from the air will not be getting in, but will instead, carbon dioxide from inside our body will have to diffuse out. That's through the respiratory membrane. And then driving this 104 millimeters of mercury now, driving it down into the arteries, the blood in the arteries, the oxygen level is now 100 millimeters of mercury pressure, and your carbon dioxide is actually only 40. In the tissues now, take a look at what's going to happen in the tissues. In the tissues, your oxygen is now taken in, and therefore the oxygen level drops down to 40 millimeters of mercury. Imagine the difference from 100 millimeters now to 40. Okay? And then your carbon dioxide now is going to be increased because of the extra carbon dioxide that's released in the tissue. So now your venous blood now will carry 45 millimeters of mercury pressure of carbon dioxide, and it will be carrying less, very, very little of the oxygen, from 100 to 40 millimeters. So that means about 60 millimeters of mercury pressure of oxygen is being absorbed into the tissues. And you know what happens to the oxygen there, right? Oxygen is being used by our cells to produce ATP. So that's why we need a lot of oxygen. So having said that, this now oxygen poor blood is now going to be delivered again into the alveoli, and take a look at what's going to happen. The only thing that's going to happen there is actually by way of diffusion for oxygen from an area of greater concentration will diffuse towards an area of lesser concentration. So here you have your PCO2 again, that is what do you call this, 160 millimeters of mercury pressure, and your alveolar oxygen, which is 104, it will now be taking in oxygen because the oxygen that is being delivered to the lungs has only 40 millimeters of mercury pressure. A lot of oxygen will have to be taken in order to equalize what is actually outside. Okay. So the external respiration, okay, pretty much is affected by the thickness and the surface area of your respiratory membrane. And your respiratory membrane is usually very thin, about 4.5 to about 1 micron in thickness only. And the large surface area of the alveoli is 40 times the surface area of the skin. You can just imagine, right? You think that our skin really is the largest organ, okay, because of its thickness. However, with surface area, the lungs or the surface area of the alveolar sacs of the lungs cumulatively outnumbers the surface area of the skin by 40 times. So, the effective thickness of the respiratory membrane would increase dramatically if the lungs become uh, waterlogged and edematous. So, pretty much as seen in pneumonia. In uh, 0.70 in 0.75 seconds, red blood cells spent in transit through the pulmonary capacity capillaries may not be enough for adequate gas exchange. So the result of this, body tissues suffer from oxygen deprivation. So your respiratory membrane must be really very thin, okay, and should not be waterlogged. Certain pulmonary disease would drastically reduce alveolar surface area. Example, in emphysema, the walls of adjacent alveolar would break down and the alveolar membranes chambers would enlarge. Tumor, mucus, or inflammatory material can also reduce surface area by blocking gas flow into the alveoli, right? Here's a picture of normal lungs, okay, and here's a picture of lungs with emphysema with broken alveolar sacs. Now, here is something that is really something that we need to really know, because this is going to be in the exam, which is ventilation perfusion coupling. Perfusion is blood flow reaching the alveoli, okay, which means how much blood would actually reach the alveoli and pretty much would be able to help in the transfer of oxygen and carbon dioxide in the what do you call this, in the exchange of gas. So the blood flow reaching the alveoli is perfusion. Ventilation is the amount of gas reaching the alveoli. They should be like balanced. You should have enough blood waiting there so that there will be gas exchange, okay? And there should be enough gas that needs to be exchanged when the blood is there. If you are not, if you have very poor perfusion, no matter how good the ventilation is, you're not going to be getting enough gas, right? And no matter how much blood flow or how much plentiful your capillaries would be in your lungs, if there won't be enough gas outside, then you're not going to be breathing either. So both of them must be in the right amount so that they can help each other. So they should be matched for optimal, efficient gas exchange. Both are controlled by our local auto-regulatory mechanism. Your oxygen controls perfusion by changing the arteriolar diameter. Take note of that. Oxygen controls perfusion by changing the diameter of the arteries. Carbon dioxide level, the partial pressure of carbon dioxide, controls ventilation by changing the diameter of the bronchioles. That's exactly what their effects are. So let's take a look at the influence of your partial of your oxygen pressure on perfusion. Now, changes in the partial pressures in oxygen in the alveoli can cause changes in the diameters of the arteriole, because that's exactly what it is supposed to do. When your alveolar oxygen is high, the arterioles will dilate. When the alveolar oxygen is low, the arterioles will constrict. Imagine when the alveolar oxygen is high, the arterioles will dilate. When the alveolar oxygen is low, the arterioles will constrict. This is going to direct blood to go to the alveoli where oxygen is high. So blood can pick up more of the oxygen. The opposite mechanism may be visible in systemic arterioles that dilate the when oxygen is low and constrict when oxygen is high. Now, carbon dioxide. Let's take a look at the influence of the pressure of carbon dioxide and perfusion. Changes in the carbon dioxide pressure in the alveoli causes the changes in the diameters of the bronchioles. Where the alveolar carbon dioxide is high, the bronchioles will dilate. And where the alveolar carbon dioxide is low, the bronchioles will constrict. All right. And this allows the elimination of carbon dioxide more rapidly. So, changing the diameters of both the arterioles and the bronchioles, okay, between ventilation and perfusion would need to be synchronized. Okay, that would be like your ventilation and perfusion would be in synchrony. But your ventilation perfusion is never balanced for all the alveoli because of regional variations, okay, maybe due to gravity gravity on blood and airflow, okay, or occasionally alveolar ducts may be plugged with mucus because of some certain unventilated areas. Pretty much, okay. When ventilation is less than perfusion, right here on the left diagram right here, there's going to be a mismatch, okay. Ventilation is less and perfusion is higher, okay. The pulmonary arterioles serving this alveoli will be constricted, and pretty much there's going to have to be, okay, in order to match ventilation and perfusion, there's going to be a required decrease in perfusion so that it could balance the decrease in ventilation. All right, and the same thing happens here when there's a mismatch. When ventilation is actually greater than perfusion, then the reverse is going to happen. There's going to be pulmonary arteriole that's going to dilate, okay, to pretty much like increase the perfusion balances and increase the ventilation. Internal respiration involves capillary gas exchange in the body tissues. This is actually we are now in the body tissues. And this is where the partial pressure gradients are reversed compared to the external respiration. The tissue oxygen is lower than in the arterial blood, okay? And oxygen therefore moves from the blood to the tissues. And where the tissue carbon dioxide here is higher than in the arterial blood, okay? Because you have 45 versus 40. So carbon dioxide moves from the tissues into the blood. So the venous returning blood, returning to the heart, has a partial pressure of oxygen equal to 40 millimeters of mercury, and a partial pressure of carbon dioxide that's even higher at 45 millimeters of mercury pressure. So, again, I don't need to repeat it, okay? I have already discussed it in a previous slide. That right here in the bottom area right here, you have the partial pressure of oxygen is less, okay, than 40 millimeters because a lot of the oxygen has been taken in by the tissue for use in production of ATP, right? And then the partial pressure of carbon dioxide is greater than 45 because carbon dioxide is being released also still in the production of ATP. In the Krebs cycle, a lot of carbon dioxide is the byproduct in what it calls glycolysis and in the Krebs cycle. In the production of ATP, still in the production of ATP, we are actually producing carbon dioxide. We are plucking away C6H12O6. This is actually your sugar, breaking it down into 6 pieces of carbon dioxide. For every sugar that you are breaking down in order to produce ATP, one sugar molecule that produces 38 pieces of ATP, you are going to produce 6 pieces of carbon dioxide. So your oxygen is being depleted and your carbon dioxide is actually going up. And being that that's actually what is happening, then the pressure of these two gases will also change as it's actually going back into the venous blood. All right, guys, pretty much we are done